aside from us and from out, or maintaining happiness.
Global experts on stress and trauma treatment are gathered here today in Ferney-Voltaire, France, in a collaborative effort to develop curriculum to train frontline non-mental health specialists and paraprofessionals in emergency trauma care. I'm pleased to have with us Sushma Mehrotra, a clinical psychologist and former faculty from Ascendity Women's University in Mumbai, and Derek Farrell, lecturer in psychology at the University of Worcester. Both of them are specialists in trauma recovery and treatment and have been actively involved with the work of GIST, the global initiative on stress and trauma treatment.
GIST is trying to scale up the knowledge and the skills and take it forward to the larger masses, which was actually restricted to the mental health professional.
You're right, but it's needed because the number of people becoming traumatized, the number of people becoming anxious, the number of people responding to toxic stress and depression, we know that those numbers are increasing.
Yes.
So we have to acknowledge that that is creating a global burden.
Yes.
And that global burden is not going to be met by professionals.
That's true.
We have to use paraprofessionals in order to try and address some of those needs.
I agree with that.
And the reason why we're here is because there are lots of experts internationally that have lots of ideas of working with paraprofessionals. But what we need to do is we need to share those ideas.
Yes.
And we need to put them into a common teaching and learning program that we can then sort of consider what's the best training package that is adaptable to people's needs, that is language sensitive and is culturally sensitive.
Yes.
So the purpose of us coming together is to really try to develop what we call a core curriculum in order to be able to achieve that.
And the best spirit here is of sharing. You see, the experts here are here who have developed different types of modules, and they are all ready to share their wisdom, and we are here to integrate the wisdoms coming from the different professionals and make something more user-friendly for the frontline workers.
I'm pleased to have with us Louisa Chan-Vogli. How best support and therapy can be given to the tens of millions of trauma victims in need of care in low and middle income countries, especially during and after natural disasters and violent conflicts.
In the 10-15 years I've worked in war situations, mental health is usually an afterthought, with of course taking care of the basics first. Water, food, medical care, and very, very late then we realize, oh dear me, we have millions of trauma people, literally, especially amongst children, and what are we going to do? We have to rebuild the country after war. So I think this is a vitally important subject. I think that, for example, a country like Syria, even before the war, there were only 70 psychiatrists for 22 million people and even fewer psychologists. So the answer is not to train highly specialized psychiatrists or psychologists, but to give the essential basic knowledge and skills and practice to many people at many levels of the community, so that it's accessible, so that these people have the basics to at least relieve the initial psychological pain.
What's the most important lesson you have learned from your own professional experience?
Well, I'm a medical doctor, and what I have learned, I was working in war surgery in several countries, in Bosnia, Afghanistan, Pakistan, Ethiopia. And one of the things I learned is that wars usually last a long, long time. It's not just 2 weeks we're in there and that's finished. they usually are drawn out. Today's wars. Look at Syria, 7 years. The war in Afghanistan was 30 years. So in this period of time, we have a lot of opportunity to give what we know to the people on the ground, the residents of that community, the members of the community, a lot of knowledge that they would otherwise not have. And for example, my colleagues in all agree with me, but I was very, very actively promoting at least transferring the first life-saving triage skills to the local people, whether they are just, nurse assistants or something like that, but they need the training because those first few minutes can save a person's life, either to stop the bleeding or help with the breathing, etc.
I am so happy to have with us Dubravka Suzic. I have a couple of questions that I would like to ask you. Now, how best can support and therapy be given to the tens of millions of trauma victims in need of care in low-income and middle-income countries, especially during and after natural disasters and violent conflict?
Well, that is first of all a big question, because indeed we are talking about big numbers of people in so many different locations, in different contexts, in different social and cultural environments, and everything has to be actually taken into account. And also considering that the mental health resources are very scarce in such areas, one has to look into what generally helps the healing and the coping with the traumatic stress currently in the situation, and actually using those elements, whether this is family members, whether these are members of community or whichever way, in different forms.
I'm pleased to have with us Barbara Bauer. I have a few questions that I'd like to ask. How best can support and therapy be given to the tens of millions of trauma victims in need of care in low-income and middle-income countries, especially during and after natural disasters and violent conflict?
Use paraprofessionals or even lay volunteers that we can train in simple interventions to do the initial work, and also to be able to screen people that might need more intensive care. But I think there's a real well of talent to be tapped in local people. There's almost always a group of people that we used to call the wise aunties. And the wise aunties are usually somewhat senior women who are known in the community and are sort of looking out for people. And that's one of the key groups that I think can be harnessed to actually be given some real skills.
What's your experience with paraprofessionals or with frontline non-therapist professionals such as doctors, nurses, and teachers providing trauma care?
I started in Bosnia doing a program called Teachers as Therapists, training teachers on how to do simple interventions in their classroom to help traumatized folks, children. And I've also done a mission with Médecins Sans Frontières in Nepal, where I worked with a women's shelter that was set up with the idea of helping women who are fleeing the civil war that was to the west of us. And what had happened was that the shelter filled up with women and no one left. And so it actually became a residence rather than a shelter, a transition. And they had excellent programs in microfinance and vocational skills and job placement, and no one was taking advantage of them because they hadn't addressed the trauma. And so I was sent to train lay volunteers on how to help with the trauma, and by doing that, we had a 70% turnover of the residents in the shelter in the 5-month period I was there.
And I think the best way that these people in such low and middle income countries after disasters, etc., can be helped is through the use of non-professionals, because there's never going to be enough trained professionals such as psychiatrists, psychologists, a therapist. So I think ordinary people, paraprofessionals in the locale itself, to train them up to do and be skilled enough in providing first and second level psychological first aid, and to do trauma resolution, symptom relief, and all the other work that GIST is involved in right now, I think is the way forward, really. Particularly if you're going to meet the huge unmet need that is out there. Professionals in the West are never going to be able to meet that, so the best way is to go into the local communities, train up the key people such as tribal leaders, community nurses, schools and teachers, use the already infrastructure that is there as best as it is, and train up those people to deliver trauma-informed interventions, and particularly adaptive information processing model.
Now, is there any controversy in your mind about the use of paraprofessionals and non-therapist professionals to provide trauma care?
Well, I think the obvious one is within the field of EMDR, eye movement desensitization and reprocessing therapy. I am aware that certain individuals and certain organizations within Europe are not very well disposed towards training paraprofessionals in certain trauma relief or therapy techniques. So that is a controversy that's there. How best to overcome that, I think, is a combination of diplomacy, but also maybe sidestepping the issue and moving away from the term EMDR and using the term adaptive information processing model, and then expanding that to work with individuals and groups and adapting certain protocols which are already in the public domain, but using them for our purposes, which is to help as many people as possible to benefit from proven techniques of trauma, stress and PTSD relief.
Because I've seen that in many different countries, for example in Cambodia, in Sri Lanka, in South Sudan, and I think South Sudan can be a very good example for this. We have thousands and thousands or even millions of people, even only in South Sudan, who have lived very traumatic experiences and who are all traumatized. And there are just not enough people to look after them, especially there are no specialists, no psychotherapists, and these people are left to themselves, and still they have to go on with life, and somehow they have to find a way to overcome trauma and to find back to a normal life. So how can we do that? And so that's why I think we really need to find out how we can build up multiplication systems where all those people who are capable, they can learn how to help others to overcome or to at least to diminish the traumatic symptoms and to come back to a quite normal life.
In that regard, what's the most important lesson you have learned from your own professional experience?
I think I have two different lessons. One lesson is as an expert and anthropologist in development cooperation, where I always worked with local communities. And I had the same challenge in different other fields. Local people had to learn how to manage themselves. They had to learn how to organize themselves, how to take over their own development projects in their own communities. So that's when I came up with these training systems or multiplication systems, or in French you say training and cascade, which means that you give it down, you trickle down the knowledge, you train all, and you ask the local people, please, who are your for example, young people who are able to learn, who are willing to learn, and who are willing to work with you then and to teach to you, and you always find them.
How can all these people who need help really get it? And I think we are dreaming if we think that one day all of these people will get help, but in between, we should promote the best help that is possible. And I think we cannot only rely to highly specialized psychotherapists who will give this very good help. We need to break it down to other levels of people who are able, who are very good, who are very willing to help and who have good capacities, but maybe who don't know all the techniques to do it.
One of the difficulties that we have when we try to find out solution is the lack of human resources that are trained. So one of the main objectives that we have is to find adequate training that we can propose to be able to handle and to work with all the population.
What's the most important lesson you have learned from your own professional experience?
So what we do a lot is to first try to identify as much as possible people that are already in place and to learn more what are the resources, the knowledge, and to try to support them and to provide some additional training to them. But one of the main issue is to do supervision afterwards. So to provide the training, but to be there later on to provide supervision for a long time.
What's your experience with paraprofessionals or with frontline non-therapist professionals such as doctors, nurses and teachers providing trauma care?
Well, we have very good experience, in fact, because in some contexts, not in all the contexts, but in many contexts, there is no mental health staff. I just take an example. We are working in Central Africa. There is almost no psychologist, one psychiatrist for all the country. So what we are doing is we are training some paraprofessionals. What we found out is that it's good also to set up some protocols to help and to not only to help in terms of what to do with the patients, but also how to identify the people that are in need, and then again supervision and on-job training to be there with them. So to have an expert that is also there to support the paraprofessionals.
It's important to distinguish between what ideally would be put in place and what practically or pragmatically could be put in place in the field. And what I mean is an understanding that we should be realistic about the constraints, about the realities of the field, about the absence of any mental health care professionals in so many disaster or crisis-ridden conflicts contexts, for example. So I would say that in order to address the situation from a more practical or pragmatic perspective, we need to first of all work with groups to be more effective. We need to work with paraprofessionals. So those are people already engaged in the community on a formal or informal level, but who are there doing very important work. We need to make sure that it's using pre-existing structures. That means there are infrastructures and community relationships already in place that need to be recognized and worked with. It needs to make sense to the community. It needs to be culturally appropriate. And to scale up, we need to rely on this community network to reach as many people as possible following disaster. If you want to do a program with the women in the community, it's equally as important to meet with the men of the community. It's as important to meet with religious leaders, with traditional healers, with pre-existing cultural structures that are there already, and not to impose a westernized perspective of trauma intervention. Community acceptance is key.
I think it's very important to realise that there are a lot of people with lived experience and skills in those areas. So first of all, accessing people, people who are professionals, people who are skilled individuals, but who may not necessarily be mental health professionals. So those are the people like, for example, midwives would be the group that I would be working with, that we can look at identifying how we can give midwives as experts in that perinatal period, how we can give them the skills and to be able to have mental health skills that sit alongside. And then likewise in a traumatic situation, disaster in low and middle income countries, how we can look then at other, for example, poly nurses and how we can give a poly nurse now also additionally mental health skills.
In that regard, What's the most important lesson you have learned from your own professional experience?
I think it's seek first to understand. So actually learning people from different professional backgrounds, we tend to use different terms and different language, and actually we understand a lot of the same things, but we talk about it with a different form of words and construct things in a different way. And rather than assuming that the other professionals or the other individuals do not know what we know, actually to see that they may understand it and know it and simply use different language for it. So if we sort of listen to one another more intently, we start to be able to learn how to actually talk and inform and give then look for ways that we can give additional skills rather than try just to repeat the same skills which they actually have but use different language for.
I'm pleased to have with us Pamela Lupton-Bowers, and I had a couple of questions about the workshop that we're having here. Could you outline what is GISTI trying to accomplish throughout these 3 days?
Well, my role is to accomplish what the group decides to accomplish. So obviously I was given a brief, and the brief was at the end to come up with a consensus agreement about an overall initiative for improving people's skills in dealing with traumatic stress in crisis situations, but then more specifically to agree a curriculum that could be used to train people in those contexts. So that's my brief, and my goal is to deliver on that, but not not influencing the content in any way, simply to provide a process through which the group can achieve and arrive there.
And what has been the process like throughout these days? What have been perhaps the key challenges or tasks that the group had to deal with?
The toughest challenge is getting agreement on what is the actual purpose of the initiative and getting consensus around that and simplifying it enough so it's really clear in people's minds. Then evolving from that, the objectives that the initiative is attempting to achieve in the broader sense, and then drilling down once again to the actual training program and repeating that same process in what are the objectives of the training program, and then going in a deeper dive, identifying the content that will deliver that, looking at the appropriate methodologies that will be required to deliver those objectives, looking at what the key learning messages, what do you want people to walk away being able to know and being able to do in that specific context.
This sounds like an incredible task, and having in mind the diversity of everyone's background. Could you perhaps walk us through the process and how you're allowing them to get to the place where they would actually walk away with some of the objectives achieved?
One of the things I like to do, and I find is very successful, is allowing people to sort of think on their own and to get all of their personal and individual ideas out, either written down or even sharing with one other person, and then to, at the same time as you expanding their circle of conversation and dialogue, reducing and integrating the actual ideas that come out. So you're getting bigger groups, but you're forcing them to prioritize and select, whether it's the objectives, whether it's recommendations about prerequisites for the learning. And so you're constantly, it's almost like a concertina. You're getting lots of ideas and then getting them to shape them, reduce them, consolidate them, integrate them, and then get agreement on them.
Good. How important in your mind it is to have such a gathering like this, and how could it contribute to this issue and scaling up trauma care?
Well, I was very glad to meet them here at GIST and to see that they are in the same way, because me, with my experiences of multiplication systems, training of trainers of local people, I already thought about this, and then seeing what happens in South Sudan, I said that's what we now need to apply to trauma care. And then I came across them and I learned, okay, we will have this workshop now. We will exactly work on that and try to position ourselves by elaborating first core curricula, how paraprofessionals, or as I call them, non-specialist trauma care providers, how we can do that. So to introduce, to convince other organizations to implement this in their own programs. So I'm confident that we will get a big step forward.
In these last few days, what we're engaged in is developing such a model in order to bring it to low and middle income countries, to train the very people we're talking about, the local health nurses, or possibly teachers or tribal leaders, or government ministers, whoever is influential in the local community, where it can then, an entry can be gained for this model to be promoted and to work, and obviously to be researched as well, because I think that's important. We have to be able to prove that this model works. So what we've been doing the last few days is developing the model, and I think the next steps from here will be to take it into the field, but also to develop a research model as well.